We've all heard about the term antidepressants, pharmacotherapies or medications that are designed to lift mood. Now, psychedelic treatments such as psilocybin are being increasingly studied for their potential antidepressant effects, but emerging research is demonstrating a more general effect, not just on reducing depression, but also on reducing distress and suffering at several levels. Some are even calling them antidistressants. Hello and welcome to the integration session where we explore the science, stories, and future of psychedelic science. Today our guest is Danica Johnson, a PhD candidate at the University of Toronto's Institute of Medical Science, co-supervised by Doctors Joshua Rosenblat and Roger McIntyre at the Depression Center Clinical Research Unit at Toronto Western Hospital. This group's cutting-edge work examines the effects of psilocybin and ketamine on cognitive functioning, treatment-resistant depression, trauma, and psychiatric comorbidities. Danica's research is reshaping how we understand these compounds, not just as potential antidepressants, but also as antidistressants that address suffering at multiple levels. So in this episode, we're going to break down the term antidistressant, what it means, and why it may be more accurate and useful than antidepressant. We will also discuss the multidimensional ways that psilocybin works, new findings about cognitive outcomes, and what's on the horizon for psychedelic research in Toronto and beyond. Let's dive in. Hello, Danica. Welcome to the integration session. Thank you so much for being here. It's great to have you.
Thanks so much for having me. I'm excited.
Of course. So let's give a little bit of background for our listeners first. So what initially drew you to pursue psychedelics as the focus of your PhD research? And also, how would you describe the current kind of vibe or feeling of psychedelic research in Toronto? Because I know there's so much happening there. So I'd love to get your insight on that too.
Yeah, absolutely. Yeah, this is actually kind of a full circle moment for me being on this podcast and its affiliation with Queen's and CPHR, because the reason I got into this is because of Ron Shore, who works at Queen's and is really involved with CPHR. And essentially just kind of went to one of his talks when I was in my first year of undergrad, and he was discussing psychedelics and also the limitations of our current treatments for mental health. And I think what really captured my interest wasn't necessarily psychedelics on their own, but rather the patients they may be able to help. And throughout my PhD, I've now almost exclusively worked with patients who haven't really benefited from traditional treatment. So whether it be treatment-resistant depression or somebody with significant trauma history or significant cognitive impairment, these are some of the patients with the greatest unmet need in psychiatry. And I kind of wanted to understand how we can move beyond what we currently have available to try to help these patients. And so I've kind of come to Toronto now, leaving my undergrad. And like you said, Toronto has been an incredible place to train. We have one of the largest concentrations of psychedelic researchers in Canada, I think probably the largest. And we have multiple clinical trials happening across several institutions. It's very collaborative, which I love. So I work at UHN, but we work with CAMH and Sunnybrook and St. Mike's and all these wonderful institutions. And I feel very fortunate to be surrounded by the clinicians and scientists who all share the same goal of developing treatments for people who haven't really benefited from what's currently available.
Yeah, so exciting. And this is a bit of a side note, but I also saw that there's a collaboration with an art exhibit.
Yeah.
Was your group kind of involved with that too?
Yeah, it was mostly CAMH, which Ishrat Hussain is like the principal investigator at that site primarily, but we collaborate with Ishrat very closely. And yeah, we created at the ROM, which is one of the biggest museums in Toronto. And it's a great exhibit. If anybody's in Toronto, you should stop by because it's very, very cool.
Yeah, it's so interesting. Obviously, there's a huge overlap between psychedelics and the visual nature of them and art and history. So I'll definitely be checking it out next time I'm around.
Yeah, it's worth a quick train trip from Kingston or
Yeah,
wherever you
yeah,
are.
exactly. Okay, so one of the main things that I wanted to talk to you about and bring to our listeners is this concept of psilocybin as an antidistressant. So your group recently published an article in Nature Mental Health that describes this kind of concept And you also talked about this in a recent webinar with Dr. Joshua Rosenblat, your co-supervisor. So what does this term mean, and why do you think it might be more fitting or useful than the traditional term of antidepressant?
Yeah, great question. And this is a completely fake word that Josh and I coined. So naturally, we've spent a lot of time explaining, like, what do we even mean by that? So the idea actually came from a commentary that we wrote, as you said, in Nature Mental Health, that was based on a study of psilocybin-assisted psychotherapy in people experiencing cancer-related distress. And what struck us wasn't simply that depression improved, but that is kind of what everybody expects by psilocybin right now anyway. Most trials are showing some effect on depression. But what we were really struck by is that the participants improved across a whole range of psychological symptoms. So they were looking at things like anxiety, interpersonal sensitivity, hostility, obsessive compulsive symptoms, and somaticization, I think was the other. And so this kind of made us question whether antidepressant is actually the best way to think about these treatments. The word antidepressant kind of implies a medication designed to target one specific disorder, being depression. But when you step back and look across the broader psychedelic literature, we see signals in PTSD and OCD and substance use disorders, eating disorders, end-of-life distress, even branching out into neurological conditions and chronic pain. And so while these conditions have very different causes, they all kind of share one theme, which is that they involve profound psychological distress. And so rather than thinking of psilocybin simply as an antidepressant, we proposed that made-up term of antidistressant, which would be a treatment that is focused on reducing distress across multiple symptom domains and multiple disorders. And this is just a hypothesis, it's not a proven fact, but we just think it might be a useful way of kind of reframing where the field might be heading and moving away from like a DSM-5 diagnostic, like we're checking off these boxes of this specific disorder.
Yeah, that's such a good way to describe it. And I love making up words, so I think that's really great. And just helps to conceptualize what these substances and treatments can be helpful for, and that it is, like you were saying, transdiagnostic. We're seeing this for so many different conditions and so many different mechanisms, which is what I wanted to ask about next. So people might think of antidepressants and they have kind of like a characteristic mechanism. Maybe that's doing something to serotonin in the brain. But how is psilocybin different? How is it affecting multiple mechanisms, if that's the case?
Yeah. Yeah, I definitely think there's a multitude of mechanisms happening at the same time. So I think on the neurobiological side, psilocybin has been described as a psychoplastogen, another kind of made-up term, but that has been more adopted. And this basically means that it rapidly promotes neuroplasticity, or the brain's ability to make new connections. And animal studies, for example, have shown rapid growth of dendritic spines. We also have human neuroimaging studies that suggest that psilocybin temporarily reorganizes the brain and networks in the way they talk to each other. And it actually does look different than what conventional antidepressants do. Psychologically, there's also this leading idea that psilocybin increases psychological flexibility, where many psychiatric disorders involve this stuckness. So either in like a rigid pattern of thinking, like something like rumination in depression, or a compulsion in OCD, or avoidance in PTSD. And if those rigid patterns, instead of becoming so stuck, become more flexible, then improvements across multiple symptom domains suddenly makes a lot of sense because it's all kind of interconnected. And I think like one final thing is that there is almost like an existential component as well that we're potentially looking at. So in patients facing serious illness, for example, like terminal illness like cancer, psilocybin can profoundly influence meaning and connectedness and even their relationship to like death or a fear of death. And so in that way as well, maybe we are going beyond what a traditional antidepressant is targeting just by being able to affect serotonin per se. So I think it's probably an interaction of multiple things, and that the subjective psychedelic experience would be that existential component that maybe is also connected. But again, a lot of hypotheses, and I think a lot of exciting things will come in the next few years that will hopefully give us maybe a better answer or a more concrete answer to that.
Definitely. And turning to some of your work on cognitive outcomes, because this can sometimes be a point of public concern, I feel like. So, you were the first author of a paper that reported on cognitive outcomes following psilocybin treatment in treatment-resistant depression. So, what was that study design, if you could explain it for our listeners, and what were the main findings there regarding changes in cognition?
Yeah, absolutely. Yeah, like you said, there is some concern that cognition may be negatively affected by psychedelics. And so that is a reasonable concern to have. And we were hoping to look at that. And that is really the real focus of my PhD. And the study I published is just kind of one chapter, so more to come. But our study looked at 26 adults with treatment-resistant unipolar and also bipolar depression, which was a bit different than a lot of previous studies. And they all received psilocybin-assisted psychotherapy, so there was no control group or anything. But we assessed cognition before treatment, 1 day after, and then again 2 weeks later. And we used measures that assess processing speed, attention, and executive function. And overall, we found that cognition improved across the board over time. The attention and executive function measures remained significant even after we accounted for depression. And that's something that we often see, is that depression, when it improves, other symptoms also improve related to depression improving. And what we want to see is if cognition improves independently of depression improving. And we did find that with attention and executive function, but not processing speed. So there's potentially something that is directly cognitive happening in those specific domains. But again, it's kind of too early to say. There were a lot of limitations to this study, including the fact that we didn't have a control group. And we also administered the same test at those same time points. So what happens is that, like an exam, like if you're taking an exam on Monday and you also take the same exam on Tuesday, you're probably going to do better on Tuesday than you did on Monday. And that would be just a practice related effect. So we did try to account for that. You can do that in some statistical modeling. And when we accounted for the practice effect or just the repeated administration of the test, we only found that about 4 to 12% met the threshold for what we would say is like clinically significant improvement. And that amount wasn't greater than chance. So there is some signal here that there may be some modest improvement at like a group level, and enough signal to justify larger placebo-controlled studies. But again, tampering the conclusions here.
Definitely. And were any of those improvements durable over time? Like, how long did you measure these things and follow up?
Yeah. So in terms of durability, unfortunately, we only had sufficient cognitive data through the 2-week endpoint. So the processing speed and attention tests improved at day 1 and 2 weeks. The executive function test took a little bit longer. It only improved at 2 weeks and not day 1. None of them showed decline, but again, it was just a little bit later in time. So we're actually continuing our work and doing longer follow-up periods. So in a study that I'm running currently, we're looking at 3 months and 6 months after their last psilocybin dose to try and look and see the durability of effect. Yeah.
And do you have any hypotheses there, what you think you might see?
I don't know, to be honest. I'm cautiously optimistic. I feel like it will probably be an acute cognitive effect. I don't necessarily think that it will extend, but again, everything that we've seen so far has shown me that it might just be a practice effect. So that's why I'm just very cautious to say, like, even over time, they might get better, but then are we saying that it's because they got better because they've seen the test more times, or did they get better because of the psilocybin? So I'm very open to either option at this point.
Yeah.
As long as we're not showing harm. And that's the other important piece. Like you said, there is some concern about harm. And so as long as we're not seeing cognitive decline or cognitive impairment, then I think that's still an important finding for the field as we move forward to implementation and providing these treatments to the public, for example.
Yeah, especially because a lot of the research is on different mental health applications, not necessarily as like a cognitive enhancing agent.
Exactly.
Yeah.
Yeah. That would be a cool bonus.
Definitely. But yeah, good to make sure that to do the due diligence to make sure that there isn't harm being done as the side effect of those. So definitely
Exactly. Yeah.
important work.
Yeah.
And your research group is also very well known for its work on ketamine treatments in psychiatry. So there is, as you know, robust evidence for specifically ketamine for depression. But what is the real world effectiveness of ketamine in treatment resistant depression in patients who also might have a comorbid PTSD? And also, how do the PTSD symptoms respond to the treatment?
Yeah. Yeah, so this is another publication that I came out with that was hoping to answer a very practical clinical question, which is that we know that patients with both treatment-resistant depression and PTSD tend to have worse outcomes with conventional treatments. They're often more symptomatic, more functionally impaired, and much less likely to achieve remission with standard antidepressants. So we wanted to know whether ketamine behave differently in that population, or if we could just say that it's similar to what an antidepressant does. And so we had a decent sample. So we had 134 patients in this study who received 4 intravenous ketamine infusions. And it was in a real world outpatient clinic. So this wasn't part of a clinical trial. And we essentially compared patients with treatment resistant depression alone to patients that had both treatment resistant depression and PTSD. And what we found was very encouraging. So depression improved significantly across the treatment period, and having PTSD did not reduce ketamine's antidepressant effectiveness. So in other words, people with PTSD improved just as much as the people without PTSD, which was great. And then to your question about the PTSD symptoms, we actually found an average improvement in the PTSD specific score of about 11 points, which is a clinically significant improvement. And we found it across all 4 symptom clusters. So PTSD is often diagnosed based on these symptom clusters, including like intrusion, avoidance, negative cognitions and mood, and hyperarousal. And all 4 of those domains improved. So this is a population that really struggles with conventional treatment, and yet we observed meaningful improvement in both their depression and PTSD symptoms just following 4 infusions of ketamine. Again, this is not a randomized controlled trial, so I just have to preface with that. But again, it provides some strong rationale for conducting larger prospective trials, specifically in a comorbid population, which is more similar to what we see in clinic. Like, we often don't see pure depression or pure PTSD. There's so much overlap that you often see. So
Yeah, and to your point there, it's so important to complement that randomized controlled trial evidence in a very specific population with the real world data. Like, how are patients in the real world actually doing when they have these comorbidities? Because that's more often than not the case. So I agree. It's an important area, and that the clinical randomized evidence should probably complement that, not only
yeah,
relying on like the clinical trial. So that's really
exactly. Because
great.
clinical trials are so specific. Like,
Yeah.
your inclusion exclusion criteria, they're like 20 points. And so you're getting a very, very specific population, and great if it works in that very, very specific population. But when we try to implement it in something like an outpatient ketamine clinic, now who is benefiting? How does it change the evidence from the clinical trial? What is the effectiveness now?
Yeah, yeah, definitely. And in terms of mechanisms there, why do you think that ketamine might be particularly helpful for this comorbid psychopathology of treatment-resistant depression plus PTSD?
Yeah. I think although depression and PTSD are distinct disorders, they both involve disruptions in like emotional regulation, stress circuitry, cognitive flexibility. And PTSD in particular is characterized by these rigid trauma-related memory networks and this kind of like threat learning and avoidance. But depression also has its own rigid beliefs and cognitions. And so again, there's kind of this overarching theme of like rigidity. And ketamine is an NMDA receptor antagonist, or it blocks it. And that action initiates a cascade of glutamatergic signaling that promotes this rapid synaptic plasticity, kind of what we already talked about with psilocybin. And so one hypothesis is that this kind of temporarily increases neuroplasticity in the brain and makes it more capable of updating those maladaptive emotional and cognitive patterns. So in other words, it kind of like helps people become less stuck. whether that's the depressive rumination or the trauma-related fear network. So it's kind of acting on both. And although this is a hypothesis, it really fits what we see clinically, that like there is overlap in these symptom domains. And then I think something else is not necessarily related to mechanism, but I guess something I think is interesting when it comes to this population, where we have about 43% lower likelihood of remission in this population compared with depression alone. And the only treatments for PTSD currently that are FDA approved are sertraline and paroxetine. And those take up to 12 weeks before patients actually experience any beneficial improvement or meaningful improvement. Whereas ketamine is working on a very different timeline. So it's happening rapidly. And when I say we did 4 infusions, I mean we did 4 infusions over 2 weeks. And that was already enough to show 11 points of improvement in the PTSD symptoms. And on top of that, the depressive symptoms. So now we're talking about days to maybe a couple of weeks compared to months. And when you're looking at a patient population where they have severe depression and suicidality and profound functional impairment, that speed really matters. So there's something happening there as well that I think is important, specifically for the PTSD comorbid with TRD.
Definitely, yeah, powerful results for sure. And you've also investigated whether a history of childhood trauma influences how well adults with TRD respond to ketamine. So what were the main findings regarding the effectiveness in people with a high versus a low childhood trauma load?
Yeah. So this question was slightly different than our last. So in this one, we weren't asking whether someone currently has PTSD. We were asking whether their past experiences predict treatment response. So they're related but distinct. And so in this study, we looked at 83 adults with treatment-resistant depression and categorized them according to their childhood trauma history. So you mentioned the term childhood trauma load. So essentially we administered a questionnaire that assessed experiences with like family disruption, so something like divorce, for example, violence, sexual trauma, severe illness, or like deaths in the family or friends. And then based on those scores, you can kind of split them into a high trauma load or a high trauma history, if you will, and then like a low trauma history. And 55% of our participants fell into what we classified a high trauma group, so almost a half and half split there. And across the entire sample, similar to the results I presented just previously, the depressive symptoms improved substantially following the ketamine treatment. And we had about 5.5 points, I think, on our depression scale, which is meaningful as well to the participants. And though the main thing, again, going back to the trauma piece, was that high trauma load did not predict how much someone improved. So it didn't predict who responded, it didn't predict who achieved remission or how quickly even they achieved response or remission. And then separate to that, sometimes, or not sometimes, in the literature, there is some evidence to say that specific trauma types are more associated with lack of response. So, as you can imagine, like sexual abuse or physical violence, those are often seen as more severe trauma, and those can be related to reduced response. And so we wanted to look at the specific trauma type as well. And the same thing, though, we essentially found that there was no meaningful difference across which trauma type they endorsed most strongly. And so what we see across the literature and why this is important, I kind of touched on it, is that trauma as a whole, whether it be specific types or severity, is related to poor outcomes, and that's not what we saw here. So ketamine may actually be an effective treatment option for somebody that presents to clinic with an extreme trauma burden that has tried multiple antidepressants and hasn't gotten any response. So I think that is really important for these populations who haven't received the benefit of any prior treatment. Yeah.
Definitely. And that kind of brings it back to the whole antidistressant framework that you've written about in terms of psilocybin. So when you talk about ketamine being helpful for different types of trauma, how does ketamine fit into that broader antidistressant framework?
Yeah. I think ketamine, I grouped ketamine as a kind of psychedelic. A lot of people have opinions about that, so we can debate that in the comments if you want. But I do think that ketamine is involved in this kind of antidistressant framework. And so the reason that I think that is like, there is an overlapping mechanism there. So like mechanistically, ketamine and psilocybin are obviously very different drugs. Ketamine primarily works through the glutamatergic system, as I mentioned, and psilocybin works through the serotonergic system. But both drugs converge on this idea of rapid neuroplasticity and synaptogenesis. And so this kind of fits the model where you're temporarily increasing the brain's capacity to reorganize itself and kind of like resetting a rigid and very distress generating brain state rather than treating a single diagnosis. And I think you see that in the ketamine studies that I presented. So in the PTSD study, we saw improvements across all of those symptom clusters, which weren't necessarily related to depression. Like, hyperarousal or avoidance, they aren't really super tied into depression per se. They're more PTSD symptoms. And same within our childhood trauma study. Like, if we found that trauma did impact the antidepressant response, then maybe we'd be a bit more cautious. But it does seem like across the board, if there's significant distress, these drugs or medicines are able to improve that distress. So I think there is a lot of overlap there. Yeah, it's a great question.
Yeah, definitely. Yeah. Everybody hit up the comments if you'd like to debate, because I don't know, I might be in your corner though.
Right? Yeah. If you go solely based on mechanism, as in like neuroplasticity promoting drugs, I think that's like an interesting subsection of things that we can like talk about and see, are others that are promoting neuroplasticity having the same effect, or is it something specific to the psychedelic neuroplasticity effect that we can separate?
Yeah, great question. And that brings me to the sort of broader questions that might be floating around in your research group and in your PhD work as we near the end of the conversation. So, what are those remaining questions that you're hoping to answer in your PhD work? Or at least what questions might come up or that you're thinking about?
Yeah. I have so many. I feel like every single day of your PhD is just coming up with more questions and asking yourself, how do I answer these? Like, where's the money coming from? And like, so, but like, what keeps me up at night scientifically, is probably like, are these treatments improving more than mood? And if so, like, how do we prove that? I think across every project we've kind of discussed today, I've been interested in outcomes that are beyond just a depression scale score. So things that are more broadly related to like functioning and like dimensions of psychological well-being, like cognition or like trauma related distress. And so the challenge with psychedelic research in general is just that these studies are so difficult to conduct rigorously. So all the research I presented, for example, was from our open label studies, or our real world effectiveness studies. And in RCTs, even many psychedelic trials are functionally unblinded because participants can tell whether they received psilocybin. I think you had a whole episode about this as well. So, it's a common thread among the discussions these days. And cognitive studies, again, which is like the main focus of my PhD, is really susceptible to practice effects. And there's some things you can do to avoid that, but it's not a perfect system. And I think the placebo response, again, is just so remarkably powerful. So one of my biggest questions is just like, how much of the observed benefit is coming from the drug itself? How much comes from the non-specific effects of the environment? What is due to the psychotherapy? Because right now, like with Health Canada, you can't administer psilocybin without some kind of psychotherapy or psychological support. And so that is also playing a role. And so how do these even interact? So I just think there's a lot going on. We're currently conducting some randomized controlled trials. Our big one right now that we're wrapping up is an RCT, phase 2 RCT, looking at 1 versus 2 doses of psilocybin. And we actually have a follow-up that's going over 6 months. And I think the interesting thing about that study is that the first phase of it, you'll be able to compare the patients that received the 25 milligram dose to the placebo. And then in the second phase, you're comparing the patients that received one 25 milligram dose to the patients that received the second 25 milligram dose. And so you're kind of seeing this dose response effect, which I think hopefully will help kind of disentangle some of the strictly like placebo versus 25 milligram comparisons, because if there is a benefit from an additional dose, then that is kind of suggesting more towards the psilocybin, because everything else is being held constant. Like the psychotherapy is being held constant, the non-specific effects are being held constant. So I think that's an interesting way to go about it. And we just actually recruited our last patient, and we have our last dosing on Monday for that study. So very exciting for our group. Yeah.
Yeah, that's super exciting. I'll have to have you on again to discuss what you guys find. Awesome. Well, this was so much fun. Thank you so much, Danica, for joining me for this discussion. If anybody listening is interested in hearing more about your work or staying up to date on things, where should they kind of look for that?
Yeah. To be honest, our lab isn't great with the whole social media thing. But you can, I think a lot of it gets posted on LinkedIn, like my own personal page, or Joshua Rosenblat is the PI of our lab, and he's pretty active on X as well. So definitely can follow there. And yeah, we have a lot going on. We have a couple clinical trials as well that are looking at the monitor. So like whether the support that we provide participants, if we change that variable, how does that change response? We also have psilocybin as an adjunctive to antidepressant medications, so that you wouldn't have to discontinue them off of their current antidepressant medications if it was equally as effective and safe as taking them off. And we have some new ones for Parkinson's as well, and chronic pain. So the field is so exciting, and I'm so happy to be here and talk to you about all of our research and our lab's work. So yeah, thank you so much for having me.
Yeah, of course. I look forward to chatting again in the future.
Yeah, absolutely.
Thanks
Thank
so
you.
much. Bye.
Bye.
Thanks for listening to this conversation with Danica Johnson, and thank you to the Center for Psychedelics Health and Research at Queen's University and the support of the Ontario Brain Institute, the Canadian Biomarker Integration Network and Depression, and Providence Care Hospital. Be well and integrate wisely.